Welcome back to The Explainer. Today, we're diving straight into the highly complex and honestly sometimes frustrating world of evaluation and management coding. Now, if you're a coder, a biller, an auditor, or a healthcare provider, you already know that E&M codes are the absolute backbone of your revenue cycle. So our goal today is really straightforward. We're going to optimize your legitimate reimbursement while helping you completely dodge those massive compliance minefields that trip up so many practices. All right, let's get into it.
I want you to ask yourself a seriously critical question right now. Are your EM claims actually audit ready? Because let's be real, we live in an era where payer scrutiny is literally at an all-time high. A single, simple misunderstanding of a coding modifier, like slapping it on the wrong code or just failing to justify it in your notes, can trigger a massive payer audit. We're talking clawbacks, civil penalties, the whole shebang. So consider this explainer your ultimate shield against those audits.
Here's our roadmap for today. First, we'll hit the essential EM modifiers. Second, we'll navigate the tricky telehealth rules. Third, we'll talk about the gold standard of medical necessity. And finally, we'll wrap up with a bulletproof audit framework. So let's kick things right off with Section 1, Essential EM Modifiers.
We have to start by tackling the most notorious problem child of medical billing. Yep, the heavy hitter itself, Modifier 25. The rule here is that a significant, separately identifiable EM service was performed by the same physician on the exact same day of a minor procedure or other service. The absolutely crucial takeaway here is that your documentation has to clearly prove the EM service went way beyond the usual pre- or post-op work that's already bundled into that minor procedure. You can't just do a 2-second check before procedure and call it a separate service.
To put that into perspective, think about this contrast. If you're just evaluating a minor problem solely to decide if you need to perform a minor surgery, say you look at a skin tag and then remove it right away, Modifier 25 is a definite no-go. That's entirely bundled. But what if you have a completely distinct assessment? Let's say you're treating a patient's chronic knee pain, and then, you notice they have otitis externa, so you do a separate ear lavage during that exact same visit. That easily qualifies. Your documentation just needs to show a distinctly separate history of present illness, exam, and medical decision-making.
Moving on, we have Modifier 24. This one is for an unrelated evaluation and management service by the same provider, but specifically during a post-operative global period. You know the drill. When a patient is in a global surgical period, routine follow-ups are financially bundled right into the surgery code. So to use Modifier 24, you absolutely need a separate diagnosis code that screams, hey, this visit has literally nothing to do with the patient's surgical recovery.
The distinction here is actually super logical. If a patient comes back 2 weeks after a gallbladder surgery complaining of pain at the incision site, or you're just doing a routine wound check, you cannot bill that separately. That's already paid for in the global package. But if that exact same patient comes in 2 weeks post-op for a completely new urinary tract infection, well, treating a UTI is totally unrelated to taking out a gallbladder, right? That is your perfect textbook use case for Modifier 24. Next up is Modifier 57, also known as the Decision for Surgery Modifier. You're going to use this when the EM encounter leads directly to the initial decision to perform a major surgical procedure. And by major, we mean a procedure with a 90-day global period happening on that exact same day or the day prior. And for sure, your assessment and plan documentation must definitively confirm that this was the moment the surgical decision was made.
Notice the really strict restriction here. You absolutely cannot use Modifier 57 for minor surgeries, those with a 0 or 10-day global period. It's reserved for major surgery. A great example, a patient comes into the ER with severe abdominal pain. Your intense EM evaluation confirms appendicitis, and you make the decision right then and there to proceed with a same-day emergency appendectomy. A pending Modifier 57 essentially tells the payer, look, this wasn't just a standard pre-op visit. This was the high-stakes evaluation where the decision for a major surgery was actually made.
When you really map out these key modifiers, you start to see a massive recurring theme for surviving an audit. It always comes down to having distinct clinical documentation. You need a distinct HPI, exam, and MDM. You need an unrelated diagnosis. You need the surgical decision explicitly documented. Remember, the modifier itself is just a tiny 2-digit code you put on a claim. It's your clinical documentation that provides the actual armor.
All right, let's keep this momentum going into Section 2, Navigating Telehealth Modifiers.
As we pivot into the fast-paced, constantly changing landscape of telehealth, we have to look closely at how CMS actually categorizes virtual visits. They split them into very strict buckets. First, you've got your synchronous real-time interactions. That's your standard live two-way audio and video. Then you've got audio-only telephone encounters for when video just isn't happening. And finally, you have asynchronous store and forward, virtual check-ins, and remote patient monitoring. Knowing exactly which bucket your specific service falls into is going to dictate every single thing about how you bill it. Now, listen, getting your place of service, your POS indicator wrong, is an instant denial trigger. Since 2022, the rules have gotten incredibly specific. Here is the golden rule. POS 10 is used when the patient is located in their own home during the virtual visit. This is the default for most CMS and commercial payers right now. And the best part is that reimbursement typically aligns with a higher non-facility rate. On the flip side, POS 02 is used when the telehealth service is provided while the patient is somewhere outside their home, like sitting in another clinic or a hospital.
To keep your virtual claims completely compliant, you have to draw a hard line with your modifiers here. You're going to use modifier 95 when both the audio and the video are functioning perfectly in real time. But you know how it goes. Sometimes the patient's internet completely drops out, or they just can't figure out how to turn their camera on. If it downgrades into a phone-only assessment, you must drop to modifier 93 for audio only. And a quick heads up, your documentation has to explicitly state the technology you used, and if it was audio only, you often need to log patient consent and the total duration.
Moving right along, let's jump into Section 3, the Medical Necessity Gold Standard.
Okay, we've covered the mechanical modifiers, so now we need to talk about the ultimate shield, the framework you must use to defend every single code you submit. I want you to burn this overarching rule into your memory. Medical necessity determines whether a service is justified and payable, not just whether it was performed. Seriously, regardless of how many data points you tick off on your coding matrix or how much time you spent chatting with the patient, medical necessity is the absolute gold standard. If your diagnoses and treatment plan just don't justify a complex high-level code, like billing a level 5 visit for a mild self-limiting cold just because you reviewed a ton of old chart data, you have to downcode. It's absolutely crucial for compliance.
And this brings us to a massive, flashing red warning regarding electronic health record copy-paste hazards. If you are just blindly copying or cloning prior notes for a chronic condition without actually updating the patient's current clinical status for today's visit, well, actually, scratch that. You aren't just begging for an audit. You're practically walking into a False Claims Act violation. The DOJ and OIG actively hunt for this. Repeating identical notes across multiple visits is a huge compliance risk. You always have to ensure the documentation uniquely matches the intensity of the service you provided on that specific date.
Let's bring it all home in Section 4, the Audit and Compliance Framework.
When we pull all this together and look at the top triggers, these are the highest frequency denial reasons that commercial payers and the OIG are aggressively hunting for right now. First, upcoding, when your medical decision-making just doesn't support the high-level code you build. Second, unbundling. This is where practices fail to use modifier 25 properly and try to sneak in a separate EM charge when it was really just a minor procedure visit. Third is time-based abuse, providers forgetting to explicitly log the exact total time spent on the date of service. And finally, what we just talked about, clone documentation.
So how do we combat those triggers? You implement a master audit framework. Before a single claim goes out the door, step 1, cross-check that medical decision-making matrix against the actual clinical data you reviewed. Step 2, if you're coding based on time, verify that the exact total time spent and the specific activities you performed are explicitly written out in the note. And step 3, ensure you have a clearly distinct history of present illness, exam, and MDM to justify any modifiers you're using, especially our old friend Modifier 25. By rigorously following these specific steps, you guarantee that your EHR documentation perfectly matches the intensity of the service you are billing.
Ultimately, precision coding isn't just about regulatory compliance or checking off boxes on some auditor's spreadsheet. It's about accuracy. It's about capturing the true, complete clinical picture. So I challenge you to review your charts today and ask yourself, do my notes truly reflect the incredible, complex care I'm providing to my patients? If they do, your reimbursement is naturally and compliantly going to follow. But as AI auditing tools become the absolute standard for insurance companies, I'll leave you with this provocative thought. Will your documentation be strong enough to defend itself when it's a machine, not a human, reading it? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.